I would like to introduce our next speaker, Dr. Soham Dasgupta. Soham Dasgupta completed his medical school training in India, followed by pediatric residency training at the University of Texas Medical Branch in Galveston. He then went on to complete pediatric cardiology fellowship at Emory University in Atlanta, followed by advanced training in pediatric and adult congenital electrophysiology at Boston Children's Hospital. He is currently an assistant professor in the Division of Pediatric Cardiology at Norton Children's Hospital, a position he accepted back in June of 2021. Thank you so much for joining us, Dr. Dasgupta.
Hi, good morning, everyone. Can everyone hear and see me okay?
We can hear and see you perfectly.
Perfect. Well, thank you, Dr. Perota, for that introduction, and thanks to everyone that has joined today. Real pleasure here talking in front of everyone. So my topic today is to discuss challenges with device implantation in adults with congenital heart disease. And I must say, nothing instills more fear when an ACHD provider calls you at 7:30 in the morning and saying that we need to talk about a new device implantation in one of our patients. And it's because they're challenging and they can be complex and it requires a multidisciplinary team effort. And I'm going to share some of those examples with you. Let's see. I do not have any disclosures. The only disclosure I will say I have is if you all listened to Dr. Johnsrude's brilliant talk last night, I will be using one of his case examples as well during my talk today. So the objectives of this talk is review basic anatomy of certain types of complex congenital heart disease, review some unique challenges of device implantation in this population, and we will focus on a lot of case examples along the way. But a quick introduction to kind of a background to what we're going to talk about. There are certain arrhythmias that are intrinsic to specific congenital heart disease. So specifically, and you heard Dr. El-Assad talk about it this morning, was WPW, and you see it commonly in patients that have Epstein's anomaly of the tricuspid valve, congenitally corrected transposition of the great arteries, and there's also an association with patients who have hypertrophic cardiomyopathy. On the other hand, sinus bradycardia may be due to an absence or abnormal development of the sinus node and commonly seen in patients with heterotaxy syndromes. And AV block may be a result of abnormal development of AV node/His bundle fibers or AV nodal inflammation from maternal antibodies. So commonly seen in patients with congenitally corrected transposition of the great arteries, where there is a non-trivial risk of spontaneous AV block over their lifetime. Common AV canal defects, and typically from maternal antibodies in moms that have lupus or Sjogren syndrome. However, these are arrhythmias that were intrinsic to patients with certain kinds of congenital heart disease. However, there are also arrhythmias that can occur secondarily after congenital heart disease surgery. So typically, again, Dr. El-Assad spoke in detail about atrial tachycardia. These could happen secondary to re-entry circuits, abnormal automaticity from injured myocardium, suture lines, or patches. And we commonly see it in patients that have atrial septal defects, detransposition of the great arteries who've undergone a mustard or a Senning procedure, single ventricle physiology, status post-Fontaine procedure, or in post-op tetralogy of Fallot patients. Sinus bradycardia could be a result of a direct injury to the sinus node or the sinoatrial nodal artery. And it's commonly seen in patients with detransposition of the great artery status post a mustard or a Senning, or a single ventricle physiology, again, status post a Fontaine surgery. Complete AV block is not uncommon in these patients after heart surgery, and it could be a result of a direct injury to the AV node or His bundle system, seen in post-op subaortic stenosis, aortic valve replacements, prosthetic AV valves, and these are just to name a few. This list is not complete. There are a lot of other lesions that could cause similar abnormal heart rhythms. And finally, ventricular tachycardia could be a result of re-entry, abnormal automaticity from injured myocardial tissues, sutures, patches, and again, commonly studied and best studied in patients who have tetralogy of Fallot that have undergone surgical repair, but also seen in patients that have a mustard or a Senning procedure. With that background, I've talked a lot about a mustard and a Senning. So what is this mustard? And gosh, I've also mentioned a Fontaine. So what is this Fontaine? To understand anatomy and challenges of device implantation, I think we need to do a quick dive into the basic anatomy of these lesions. So Detransposition of the great arteries, as we kind of described earlier this morning, was where patients have AV concordance. So the left atrium and the AV valves, so the left atrium connects to the LV, the right atrium connects to the RV. However, there is VA discordance where the LV then goes into the pulmonary arteries instead of the aorta, and the RV then goes into the aorta instead of the pulmonary artery. And commonly, the surgery that is employed is something known as an arterial switch, where literally the surgeons switch the arteries and they connect the aorta to the LV and the PAs to the RV. Easier said than done, but that's the surgery that's commonly employed. However, years back, they used to do something called an atrial switch. And it's called a mustard or a Senning, dependent on whether intrinsic cardiac tissue is used or not. In this surgery, the systemic veins, in this case the SVC, and the IVC are baffled over to the pulmonary venous atrium, which is in this case the LV that then goes to the PAs, and the pulmonary veins then connect to the systemic RV, which then goes into the aorta. And as you can see, here there is separation of the blue and the red blood, where the blue blood goes to the lungs, the red blood goes to the body. However, one important aspect of this is the RV is the systemic ventricle, which is then responsible for pumping blood to the body. And embryologically, the RV is not meant to handle that degree of afterload. And that can lead to a lot of problems, as we shall see. On the other hand, let's talk about a Fontan. The classic lesion to understand a Fontan is someone that was born with hypoplastic left heart syndrome, where the left side of the heart is small. So the LV, the ascending aorta, the mitral valve, to varying degrees can be small or atretic. And it undergoes a staged palliation, meaning there are 3 different surgeries that are done to reach a Fontan. The first one is typically known as a Norwood, where the native aorta and the PAs are patched together to create a neo-aorta, and an atrial septal defect is created, and a BT shunt is created to provide blood to the lungs. This, after a few months, typically 4 to 6 months of age, is followed by a Glenn surgery, where the SVC is specifically disconnected and connected to the PAs to offload the ventricles. Finally, culminating in a Fontan, typically around 3 to 5 years of age, where the SVC and the IVC are both joined to the PAs. So as you can see, all the systemic veins from the head and from the lower extremities come to the PAs, that then goes to the lungs, and all of that oxygenated blood then comes back into the atrium, that then goes to the RV, goes to the aorta. Again, in these patients, the RV is the systemic ventricle, and again, not supposed or not made to handle that degree of afterload, which can lead to long-term issues. So bradycardia in ACHD, like we talked about, could be because of pre-existing congenital heart disease, such as heterotaxy syndromes, or after post-op surgery, such as a Fontan or a mustard, and typically diagnosed with H&Ps and non-invasive tests, ECG, Holter's, stress testing. And we have certain specific indications for a pacemaker, and that can include fatigue, dizziness, syncope with concomitant documented bradycardia. By that, I mean symptomatic bradycardia. You could be fatigued and dizzy for multiple reasons. For example, not drinking enough water, but you have to rule out other causes before saying that the bradycardia is responsible for your fatigue, your dizziness, or passing out, because implanting a pacemaker or a device in these patients can be a big deal. And again, as I said, pacer implantation can be challenging. Earlier today, Dr. Rayban and Dr. Al-Assad went over the pathophysiology and kind of the outcomes and a lot of the data. What I'm going to focus on is show you some of the case examples that can show or that demonstrates how challenging device implantation can be in these patients. So first case. So we had a 36-year-old male who had detransposition of the great arteries, underwent a mustard surgery, and he had a history of atrial flutter. And he was managed medically with sotalol and Eliquis. Eliquis was anticoagulation to prevent thromboembolism. He also had severe systemic RV dysfunction. Again, coming back to the fact that the RV is not meant to handle those afterloads, and the RV over time can become dysfunctional. He unfortunately had an out-of-hospital resuscitated ventricular fibrillation cardiac arrest. His downtime was not significant, and thankfully he had no neurologic sequelae. So he, at this time, had multiple indications for pacing. He had significant bradycardia because we were trying to suppress his abnormal heart rhythms with antiarrhythmic drugs. And as Shelby Manjo talked about it a little while ago, antiarrhythmics can have side effects, one of them being bradycardia. And he also had sinus pauses, which we noticed on telemetry, so he needed a dual chamber pacemaker. On the other hand, he also had clear indications for an ICD. He had out-of-hospital cardiac arrest, and he had severe systemic ventricular dysfunction with an ejection fraction of 10 to 15%. And we also noted non-sustained ventricular tachycardia. So again, real quick, a mustard. This is the SVC limb, that's the IVC limb, and somehow I have to get a pacing lead or an ICD lead across the systemic veins into the apex of this LV. The question is, this can be challenging because this is not a typical anatomy that you would see in someone without a mustard surgery, and these baffles can be stenotic. These baffles can be a little unusual because of the way it is constructed surgically. And also, surprisingly, this patient from the left side or the left axillary vein had complete venous occlusion of his left axillary venous system. So what we actually had to do was perform a device implantation from the right side of the heart. We obtained a venogram from the right side, and you can see over here, this was a remnant of the right atrial appendage that we were going to target in this patient. Typically, I would put something in the left atrium or left atrial appendage over here, but wherever we put an atrial pacing lead over here, there was phrenic nerve capture. And of course, you don't want to leave someone with phrenic nerve capture and sinus node dysfunction who will potentially be pacing his atrium a lot, and that would be really uncomfortable for the patient. Okay, so as you can see, a right-sided ICD and device implantation was accomplished. You can see the ICD coil going into the LV apex and the atrial lead right over here. You can see it better on the lateral, kind of coiled up in that right atrial, a remnant of the right atrial appendage. Okay, case number 2. So in this situation, we had a 20-year-old who had tricuspid atresia. So that's another form of single ventricle or another case of single ventricle physiology, who underwent a Fontan surgery. This patient was complaining of fatigue and also had unexplained syncope. We performed a non-invasive ambulatory monitoring with EKGs and also Holters, and we noticed significant sinus pauses for this patient. So as a result, this patient met criteria for implantation of a pacemaker. The patient underwent the CAT study, showed good Fontan hemodynamics. He also had bilateral SVC. So he had a bilateral bidirectional Glenn. As you can see, he has an LSVC and an RSVC that join his pulmonary arteries. And of note, as you can see in this diagram, I hope you can see my arrow, this RSVC or the right-sided SVC is really small compared to the left-sided SVC. An EP study was done which confirmed severe sinus node dysfunction. The AV node worked great. So we said at this time, we need an atrial pacemaker. But again, remember, if you can see where the Fontan baffle is highlighted, this typically separates the systemic venous circulation from the pulmonary venous circulation. So how do I pace the atrium in this patient? The obvious thing to do would be to consider a sternotomy and an epicardial atrial lead placement. The problem with that is it is a sternotomy, and that has its own risks with significant recovery times. So what we then did was we took this patient to the EP lab during the EP study, and we performed a voltage map of the Fontan baffle. And what it showed was there were islands of tissue in the Fontan baffle that had good voltages, healthy tissue, and potentially areas where if we could place an atrial lead would capture the atrial tissue and provide atrial pacing for this patient. Again, if you remember, this patient had a very small right-sided SVC, so the approach would be from the left subclavian vein, LSVC, across the PAs, coming into the Fontan baffle, and then find that sweet spot to try and land a lead. So again, that's what we did. We performed venograms to kind of identify the location of where we would try and land this lead, identify the anatomy, and we were able to place a 3830 lead from that left-sided vein all across that PA anastomosis and then come into the Fontan baffle. And you can see on the right, there is an X-ray showing where that lead landed. And we had excellent atrial capture thresholds, and we were able to provide atrial pacing for this patient without undergoing a sternotomy. Again, the difference is multiple days of recovery after a sternotomy versus we watched this patient overnight, and next morning, once everything looked good, we sent the patient home. Okay, case number 3. So this is the one that Dr. Johnsrud discussed yesterday, but I had to discuss it again. So this was a 32-year-old male who had a secundum ASD, underwent closure, and he had post-op cardiomyopathy. And the cardiomyopathy was typically mostly isolated to the right ventricle, although the LV was also affected. And he underwent something known as a Batiste surgery at age 15, which is an RV reduction surgery to theoretically help with this function. There have been multiple challenges that have now been published with that surgery, and we typically don't do it. But even after that surgery, the RV was so dysfunctional, it could not handle the volume load from the IVC and the SVC. So what then happened was the SVC was then connected to the PAs, almost like doing a Glenn anastomosis, also known as a 1.5V repair. A tricuspid valve annuloplasty had to be done, and that is not uncommon with reduction surgeries. And this patient needed a dual chamber and this patient got a dual chamber epicardial ICD. The indications for putting an ICD were this patient had a history of VT, sustained VT, and also significant cardiomyopathy. However, as Dr. Johnsruth said yesterday, one fine day he walked into clinic and they noticed that that ICD coil had fractured and it needed replacement because he clearly needed it. So what were the options here? Do we do a repeat sternotomy with its risks and comorbidities, or could we think of another way to help this patient? So this is a picture of the voltage map of the RV that was performed in this patient. And you see these areas of red. These are areas of extensive scarring. And as you can see, the whole RV or the most of the RV is just filled with diffuse low voltage areas suggestive of cardiomyopathy. So in this situation, what was done was an angiogram was performed. And I'm going to pause it right here. So an angiogram was performed from above, and you can see the SVC going into the PAs, and you see the red arrow showing the right atrium. And you can see a little bit of fat pad or a gap between the two. And I think on CT, they said there was 1.5 centimeters of mediastinal fat pad between the two structures. So the thought process was, is there a way we could go from the PAs into the right atrium to put a defibrillator lead in this patient? So with the help of our interventional cardiology doctors, what we were able to do is, I'm going to pause this here again, is actually puncture from the PAs into the right atrium, put a covered stent to kind of cover that gap. And using that covered stent, we were able to land a lead across the annuloplasty ring into the right ventricle. So there we go. So you can see we've gone through that covered stent. You can see the shadow of the stent right here, and then gone across the tricuspid valve annuloplasty ring and into the RV to provide ICD defibrillation capabilities. And this is a post-op chest X-ray. You can see the ICD lead, and this was a coil that was placed. So currently, this patient had two separate devices. One is an epicardial system that is just being used for pacing, and what we call quote-unquote shock box for defibrillation. With this strategy, we were able to avoid a sternotomy in this patient. Okay. The fourth case that I wanted to discuss was a 47-year-old female who had detransposition of the great arteries, who underwent a mustard procedure. Everyone's a pro about the mustard right now. This is a recurring theme. And she had a transvenous dual chamber pacemaker implanted for sinus node dysfunction in 1994. However, pacemaker interrogation in 2023 showed several runs of sustained VT, and she actually felt these runs. She felt palpitations, she felt dizzy. Thankfully, she did not have syncope. And despite multiple antiarrhythmic medications, she continued to have runs of VT. So we all agreed that this is a patient we should consider implanting a defibrillator in. But how would we accomplish this in someone with a mustard? So we had multiple options. We said we could extract her current pacing system and replace it with a dual chamber transvenous ICD. The caveat to that was her pacing system was already close to 30 years old. And after discussing the risks and benefits with her, the patient, and as part of shared decision-making, she elected not to undergo extraction of the system. The next option would be to add an ICD coil to the existing system. However, that would mean 3 leads across a mustard surgical baffle with its risks of baffle stenosis and secondary risks thereof. The third option would be to do a sternotomy and do an epicardial ICD system, similar to a shock box. However, that includes a sternotomy. And again, as part of shared decision-making, we elected not to proceed this way. And the fourth option was, could we get some sort of another system, such as a subcutaneous ICD in her, and avoid having to manipulate her intravascular space at all? So this is again what a mustard looks like. She already had a dual chamber pacemaker that was implanted. So a subcutaneous ICD is an ICD by definition that is subcutaneous. It is not in the intravascular space, and it typically has a generator or battery that lies on the lateral chest wall, and you have a lead that is tunneled across the skin or below the skin, and then a lead that is tunneled right above the sternum or the breastbone, and it provides a potential shock for abnormal ventricular arrhythmias. However, we had to be careful in her because she had severe sinus node dysfunction and was already pacing. So when we screen someone for subcutaneous ICDs, we have to make sure that they don't double count, which would mean an inappropriate risk for shocks. So when we screened her with AAI pacing or atrial pacing at different heart rates. And with the fear that these patients are not at trivial risk of developing AV block, whether it's iatrogenic from medicines or spontaneous, we also performed DDD or dual chamber pacing and made sure she's screened in. And thankfully, in all specific configurations, she screened in for a subcutaneous ICD. This was a long discussion, drawn out over months. And finally, she elected to proceed with a subcutaneous ICD. And as you can see, this is what we did and how we accomplished it. You can see her pacemaker. So if any of you are watching carefully, you will say that this pacemaker is in a very atypical location. It's typically up higher in the shoulder, below the pectoralis muscle or above the pectoralis muscle, but she wanted this to be tunneled for cosmetic reasons, and it was done by a plastic surgeon. You can see our existing pacemaker with pacing leads, and now you can see the addition of the subcutaneous ICD, which is on the lateral chest wall, and you can see the AP and lateral chest x-rays with a lead that goes along the sternum, along right next to the midline, that provides potential for shocking her out of dangerous ventricular arrhythmias. And the final case I will discuss is a 20-year-old female who had tetralogy pulmonary atresia, who underwent repair and had RV to PA conduit replacement as a child. Recently, she had severe RV to PA conduit stenosis, and she underwent replacement of that conduit, and she also had left ventricular outflow tract resection because of muscle bundles that needed to be resected. Unfortunately, postoperatively, she had complete heart block with no junctional escape, and she was supported with temporary pacing wires. After waiting the traditional 7 days, when her complete heart block did not resolve, we said, okay, she needs a permanent pacemaker. And so the options for a permanent pacemaker in her would be, yep, a traditional left-sided transvenous pacemaker. However, she had a left superior vena cava or a persistent left SVC to the coronary sinus. We have implanted permanent pacemakers through this approach, although it can be a little challenging. Then her right-sided veins were open, and we were certain that we could get it from the right side. However, I'll show you an X-ray. She had hydrocephalus and has a VP shunt. And her VP shunt that goes from the brain into her peritoneum literally traversed to along where we would have to put in the leads and make the pacemaker incision. And after talking with neurosurgery and cardiac surgery, they thought that the risk of putting it right next to a VP shunt was too great. God forbid that system got infected, then you're also putting the VP shunt at risk for infection, and that's something that we did not want at all. So the other option was, what about leadless pacing? So leadless pacemakers, such as from different companies, are now available, and this is relatively newer in the pediatric and adult congenital population. And typically what happens is you go in through either one of the femoral veins, right or left, and you put this system that's in the ventricle. Now there's also dual chamber leadless pacing, and there is no external generator, there is no leads. That's why it's called leadless. However, just to make things more fun and interesting, she also had complete right femoral venous occlusion. So the only way we could accomplish this was to use the left femoral vein. Again, as part of shared decision-making, this was the route the family elected. So on the first X-ray, you can see where the VP shunt traverses, and that's typically where you would make an incision and where you would put a right-sided pacing generator. So we elected not to go there. And on the right side image is a contrast injection from the left femoral venous vein the day I put in the leadless pacemaker, and you can see that it showed patency all the way up to the right atrium. And so we elected to put a leadless pacing. You can see on the left how the catheter goes across the tricuspid valve, and there was the final location of the leadless pacemaker. This leadless pacemaker is the size of a quarter. As you can see, there are no wires that are attached to it. There's no generator. And for someone that was recovering from post-op heart disease, the family really liked the idea of not having an external generator, also with the challenges with her anatomy. So in conclusion, it is critical to understand the underlying anatomy prior to invasive procedures in adults with congenital heart disease. Review of prior operative notes, prior surgical notes is critical to ensuring success. As you can see, innovative strategies are often needed to achieve appropriate device placement, and I cannot emphasize the need for cross-collaboration between subspecialties to obtain or achieve a successful outcome. Well, thank you very much. I'm ready for questions.
Thank you so much, Dr. Dasgupta. That was an excellent talk. We have a question from the audience that asks, what is the incidence of atrial dysrhythmias after implants or atrial septal defect occlusion, and how are they handled beyond medications? So for those of you who aren't aware, an atrial septal defect is a hole between the top two chambers of the heart that can sometimes be closed in the cardiac catheterization lab with a metal plug. And we do know that there are increased arrhythmias after that procedure sometimes.
No, thank you for that question. I must admit that I do not know the statistic off the top of my head. And if Dr. Kurtz is on, I can also defer to him. But in anecdotally, which again is not a substitute for statistics and data, I have not encountered significant arrhythmias that have needed intervention per se. They've pretty much been non-sustained or very temporary after the device. Again, it depends on the kind of arrhythmia we're dealing with. So if we see non-sustained atrial tachycardia, which we think is related to the device, I would let it settle and not try to overtreat because usually it should get better over time. However, if we see that that amount of atrial ectopy is triggering a different sort of an arrhythmia, for example, atrial flutter that we suspect is re-entry, then we know that that patient is at risk for having this substrate or this arrhythmia, even without, for example, an atrial septal occluder device. So that would kind of we would tailor our therapy differently because I would treat it as more of a potential problem that could happen even in the future. And in those patients, we would be more aggressive about medication and slash or even considering an ablation.
Thank you. Another question asks, are there any diagnostic testing, such as MRI, that can not be utilized because of these ICDs, pacemakers, whether they are wireless or wired?
So glad someone asked that. So back in the day, there were some disqualifications for ICDs and pacemakers that you could not obtain an MRI. Typically, they would be epicardial, so anything that's placed surgically by the cardiac surgeon. The old pacing and defibrillator leads were not MRI compatible. Currently, most and if not all pacing and defibrillator leads are MRI compatible. And the second thing that would disqualify someone is if they had abandoned leads. What I mean by that is, for example, a child had an epicardial or a surgical pacemaker during infancy, and later I put in a transvenous system. So even though the transvenous system is compatible, those epicardial leads are now abandoned, and that makes or would make someone disqualify someone from an MRI. That being said, there has been a lot of data over the recent time, both in adults and pediatric patients, that have shown that we could do MRI in these patients safely under certain conditions, even with abandoned leads, even with epicardial leads. Leadless pacing is MRI compatible. Okay, so the questions that I ask if someone requests an MRI in an MRI incompatible patient is the MRI absolutely necessary? Is there an other test that could supplant an MRI and provide the same information? Is it critical, and will it change management for the patient? And then finally, how dependent is the patient on the pacemaker ICD? Are they completely dependent and their heart rate is zero without a pacemaker? Have they used their ICD many, many times over the last few years? And then making a shared decision making to make sure that we understand the risks and benefits of getting the MRI. That being said, we can pretty much do MRIs in all these patients with the right supervision and after the right discussion.
Thank you. How about utilizing an AED on a patient that has a wireless ICD? Do you have any suggestion for the placement of the pads?
Um, I guess for a wireless ICD or a wireless pacemaker, right? For a leadless pacing, I'm guessing.
I think they might mean an ICD.
Okay. So I would place the pads exactly how you would place it in any other patient. So when you are utilizing an AED, you're usually utilizing it in a situation where there is an emergency. right? The patient's gone down unresponsive. And even though the patient has an ICD, remember, this is, after all, a device. Malfunctions can happen. So either the device is not sensing it appropriately and will therefore not shock, or there is an issue with the device where it will not provide a shock, in which case the AED becomes the life-saving maneuver. So even though the patient has a defibrillator, for example, I would put it based on the ACLS, PALS, and BLS algorithm. I would place it in exactly the same spot.
Thank you. Someone else asks, instead of a sternotomy in difficult cases, can you consider a subxiphoid approach for an atrial lead? And maybe explain a little bit about what that means.
Yeah, absolutely. Great question again. So subxiphoid, I think the question is, can you do a limited sternotomy or a small incision right below the subxiphoid process and then access the heart to provide a lead without doing a full sternotomy? Typically, it is easier to put a ventricular lead with a subxiphoid process because the ventricle's right there. It's a little more difficult to access the atrium. It's a conversation that we continuously have with our cardiac surgeons to try to limit the sternotomy. That being said, and this is coming from a non-cardiac surgeon, so take it with a grain of salt, is once these patients have had repeated sternotomies, there is so much scar tissue and so much adhesions. A limited sternotomy or a limited subxiphoid approach becomes really challenging, and usually you end up doing a full sternotomy to provide any sort of access to put pacing leads on these patients.
Thank you. Great question. Another question came up. What is the oldest patient you have surgically utilized an ICD or pacemaker?
The oldest patient, 75 years old. At least that's the oldest I follow.
I had one question for you. In the patient, in the first, I think it was one of the first cases that you mentioned where you placed an atrial lead in a patient with, after a mustard procedure in their right atrial appendage. Um, as some people might know, when these patients have arrhythmia, atrial arrhythmias, oftentimes we couple that procedure of converting them out of the rhythm with a transesophageal echocardiogram to first ensure that there are no thrombi in the heart or blood clots that might embolize and cause a stroke at the time of a cardioversion. And so often what we do as the echo operators is ensure that the right atrial appendage is also free of clot, since that is the side that is connected to the systemic ventricle. Can you explain a little bit about in that patient, if you altered their anticoagulation strategy, knowing that the lead was in the right atrial appendage?
I'm glad you asked that. So I guess the right atrial appendage in this case is a misnomer. So it's the remnant of the appendage coming out of the baffle side in that patient. So it was still on the systemic venous side. So typically we would go deeper into the baffle and put it on the left atrial appendage, which is the traditional place we would put it. However, phrenic nerve capture was extremely difficult, and or to avoid it was extremely difficult in this patient. So not all patients have this remnant, but when we did the angiogram, we noticed it. So we were able to put the lead there. And so thankfully it was on the systemic venous side and we didn't have to alter their anticoagulation. That being said, he was already on Eliquis for the other reasons we mentioned. The one challenge with that was because it was in a different spot that we put it, typically anti-tachycardia pacing is sometimes able to get these patients out of atrial arrhythmias. I think because it was so far away from his intrinsic circuits, we were never able to ATP or anti-tachycardia pacing pace him out of any of his atrial arrhythmias. So that was one of the limitations of putting the lead there.
That's so interesting. Thank you.